Good afternoon, Mr. Chairman, dear colleagues. Hemoglobin A1c analysis. What I want from the laboratory, a clinician's viewpoint. Additionally, glycated hemoglobin is considered the gold standard for the evaluation of metabolic control of patients affected by diabetes. In fact, the two most important studies in this context, the DCCT for type 1 diabetic patients and the UK PDS for type 2 diabetic patients, have shown that when HbA1c is reduced of 1%, the rates of chronic diabetic complications is reduced of 25%. But when the patients affected by type 1 diabetes started the follow-up of the DCCT study, the HEDIC study, you can see the levels of HbA1c increase during these years of the HEDIC study. But if we see at the chronic diabetic complications, patients in the DCCT that have an intensive therapy with respect to those that have a conventional therapy, during the HEDIC study have a reduction of the progression of retinopathy and the reduction of the onset of microalbuminuria. Monnier et al. Have tried to see what is the relationship between plasma glucose and HbA1c. And you can see that when HbA1c is good, 7.5% or lower, the contribution is mainly due to postprandial plasma glucose. On the contrary, when the HbA1c is high, that means higher than 10%, the contribution of plasma glucose is mainly fasting hyperglycemia. Further, the HADAC study tried to evaluate, utilizing for the evaluation of plasma glucose, the glucose monitoring, tried to evaluate what is the relationship between HbA1c and glycemia during the day. And the HADAC study, I participate in this study, confirmed that there is a strict relationship between plasma glucose and HbA1c. On the basis of the HADAC results, ADA suggests that it is important to take into consideration not only the mean values of plasma glucose linearly correlated to HbA1c values, but also the glycemic range. This means, for example, that if I have a value of HbA1c of 7%, this corresponds to a mean glycemia of 154 mg/dL, with a range of glycemia between 123 and 185. The glycemic range is considerably high, 60 mg/dL, and this determines a series of clinical problems in terms of attribution of a patient's metabolic control, good, acceptable, poor, and therapeutic intervention. In an attempt to evaluate with the mass spectrometry method glycation of alpha and beta globins, you can see that both alpha and beta globins are glycated. But when the metabolic control is poor or is bad, there are other peaks. These peaks are due to oxidation products of glucose. And when we try to plot HbA1c levels evaluated with the conventional methods with simply glycated or alpha and simply glycated beta globins, what you can see that the correlation is not very high. The correlation became acceptable when we correlate HbA1c with the glycosylated alpha and beta levels obtained by mass spectrometry. But there are also some non-glycemic variables that we have to take into consideration when we look at HbA1c levels. Age is important in determining some variation of HbA1c. and we don't know what is the best levels of HbA1c in patients young. Also, increase in adult age might be a problem. What you can have in mind is that when a patient is older, the rate of glycation is a little bit higher. Looking now at the patients with diabetes that are very old and have a lot of complications, what you can see is that mortality and cardiovascular disease and strokes are very elevated, both in patients that have an acceptable HbA1c, that means lower than 7%, but also in patients that have HbA1c higher, that means higher than 79%. Ethnicity is very, very important, and there is a lot of studies that have demonstrated that ethnicity is very important, also if the causes are not very clear. And also the glycation gap is important. The glycation gap is based between the no good correlation between HbA1c and plasma glucose levels. There are a lot of motivation that can increase this glycemic gap. And the most important is the genetic determinants of HbA1c. In fact, recent meta-analysis on genome-wide association studies have revealed 60 loci associated with HbA1c in multi-ethnic population. Some loci are located near genes known as monogenic causes of disorders of erythrocytes. So, specific genetic variants that have a large impact on HbA1c levels might influence clinical practice in terms of diabetic glycemic control and in terms of diabetes diagnosis. In this context, glucosamine 3 kinase, FN3K, is an intracellular enzyme involved in deglycation, active in removing ketoamines and preventing advanced glycation and products formation. And it has been demonstrated that some polymorphism of FN3K are associated with variation in HbA1c levels. In this context, Sartore and collaborators have evaluated in type 2 diabetic patients the allelic variation of NF3K polymorphism, and have showed 13 distinct variants. The most important thing is that some variants are associated with the less severe micro and macroangiopathic diabetic complications. Another important thing is the HbA1c variability. Intermittent hyperglycemia rather than chronic hyperglycemia can determine an increase in the production of reactive oxygen species, promote endothelial dysfunction, induce a release of inflammatory cytokines, and activate apoptosis. And this has been demonstrated by a lot of studies. It has been shown that patients with lower mean HbA1c levels and large HbA1c variability are more prone to have hypoglycemia episodes. Severe hypoglycemia can mediate the association between HbA1c variability and cardiovascular disease. In addition, HbA1c variability is a strong predictor for hypoglycemia, requiring hospitalization in type 2 diabetic patients. But we have also to bear in mind that large glycemic variability is also associated with poor adherence to treatment, poor self-efficacy in diabetes, poor quality of life. But the clinical application of HbA1c variability is limited because there is an absence of a standardized quantification method. As you can see, The calculation methods are lot, mean, standard deviation, coefficient of variation, Rotman square, and so on. In this paper, Lee and colleagues demonstrated that there is a strict relationship between HbA1c variability and subclinical left ventricular remodeling and dysfunction in patients with type 2 diabetes. 466 type 2 diabetic were evaluated, and the standard deviation were considered in terms of HbA1c variability. And you can see that a linear increase risk of HbA1c for each 1% elevation in HbA1c, there is an increase in left ventricular variability in patients with type 2 diabetes. In a study that has evaluated 466 type 2 diabetic patients in which HB variability was calculated with the standard deviation, the relationship between this variability and subclinical left ventricular remodeling and dysfunction has been done. And what has been demonstrated that there is a strict relationship between these two parameters. In fact, for each 1% elevation of HbA1c, left ventricular dysfunction increased from 8%. In this other study that has evaluated more than 3,000 patients affected by type 2 diabetes, mean HbA1c and HbA1c variability calculated as standard deviation predicted all-cause mortality and as well as cardiovascular mortality. In terms of secondary outcomes, mean HbA1c and HbA1c variability significantly predicted also other chronic diabetic complications and ketoacidosis. In this panel, you can see the strict relationship between diabetic complications and variability. Also in this study that has evaluated the variability on HbA1c and the variability of fasting of plasma glucose, these are the patients that were included in the ACCORD trial, show that when we calculate HbA1c variability by means of quartile, there is a strict association between the incidence of myocardial infarction and the variability both of hemoglobin A1c and glycemia. And last, I think, even when we calculate the variability of type 2 diabetic patients in 2 years, calculating the standard deviation of hemoglobin A1c, and collaborators show that large wide to visit HB variability is strictly related to the risk of cardiovascular disease in patients affected by type 2 diabetes. Another point that we have to take into consideration is the utilization of hemoglobin A1c in pregnant women. In this paper, we evaluate the value of HbA1c in pregnant women, normal, not diabetic, and we evaluate also in non-pregnant women. And what you can see is that there is a differences. Pregnant women show lower levels of HbA1c, and these levels became higher in the 3rd trimester of pregnancy. But if we look at the results of the APO study that have studied a lot of normal women, no diabetic women, and if we look at the clinical outcome on these women in terms of large for gestational age patients, cesarean section, hypoglycemia in neonate, and when we look at the correspondence levels of HbA1c, no correlations exist. Only a China study has shown that patients with normal patients have a higher frequency of preterm birth, macrosomia, and large for gestational age infants only when we look at the higher levels of HbA1c. But what about the HbA1c and diagnosis of diabetes? The International Expert Commission endorsed by ADA in 2099 recommended HbA1c for the diagnosis of diabetes and set the cutoff point at 6.5%. Successively, a series of studies taking into account data from different countries and ethnic groups have evidenced a large spectrum of differences in sensitivity of HbA1c. So, the limits of 6.5% by have a series of undiagnosed patients. So, some authors recommend the combination of measurement of fasting plasma glucose and HbA1c to screen patients with diabetes. Furthermore, HbA1c aligned IFCC resulted scarcely effective in detecting EFG in a large Caucasian population, identifying only half of the patients with abnormal OGTT. So there is an urgent need to determine the biological viability of HbA1c using specific and traceable assay, appropriate protocol, and appropriate statistical evaluation data. Now, there are many modalities of measure HbA1c: immunoassay, chromatography, mass spectrometry. But what we need is a rapid determination of HbA1c, but this rapid determination there is also accurate. And this is a meta-analysis of the performance of point of care of the HbA1c test devices, and as you can see, not all the devices are okay. So HbA1c is routinely used in clinical practice. There are categories of patients for which reference ranges should be identified: children, pregnant women, older people, non-Caucasian population. Glycemic variability in predicting the complications of diabetic disease plays an important role, but it is important to define standardized quantification methods. Development of simple methods for HbA1c quantitative assay based on portable detectors is necessary in order to implement its utilization in clinical practice. Thank you for the attention.